Bienvenue à la session scientifique du Département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du Département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated. Nous sommes réunis aujourd'hui à partir de nombreux endroits différents et dans un espace virtuel. Mais nous désirons commencer par reconnaître les terres sur lesquelles se trouve le département de médecine familiale de l'Université d'Ottawa, qui font partie du territoire traditionnel non cédé du peuple Anishinaabe algonquin. Nous vous invitons à réfléchir à votre propre emplacement au Canada par rapport au territoire où vous vous trouvez aujourd'hui. Nous reconnaissons aussi les gardiens des savoirs traditionnels, jeunes et âgés. Nous honorons leurs courageux dirigeants d'hier, d'aujourd'hui et de demain.
Nimanajiananig, mamiwinini anishnabeg, ogo ka nagadawabandajig, iyo aki ekoweshkad, akonongom egawikad ki migiwewaj. Nimanajiananig kakina anishnabeg undaje kaye ogog kakina eneagizijig, enekukamegak kanadang eje odapinagig endawajin odawang.
We are gathered today from many different locations and in a virtual space, but we wish to begin by recognizing the land on which the Department of Family Medicine at the University of Ottawa is located, which is part of the traditional unceded territory of the Anishinaabe Algonquin people. We invite you to think about your own location in Canada in relation to the territory where you find yourself today. We also acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future.
So now I will turn things to our Family Medicine Grand Rounds, January edition, which is being brought to us by Primrose. So our first speaker is Dr. Alan Ng. Alan has worked in a wide variety of environments, including general practice in the British National Health Service, in Northern Saskatchewan, amongst First Nation communities, in Myanmar with Doctors Without Borders, and in urban and suburban practice in Saskatoon and in Ottawa. Before joining the Department of Family Medicine, he did all that before coming here. And he currently works as a clinician teacher at the Primrose Family Medicine Center and is currently the lead physician for the Department for Behavioral Medicine and is a clinician educator with the Department of Certification and Examinations for the College of Family Physicians Canada. Current research interests and academic interests include the assessment of consultation in family medicine, use of medical humanities in family medicine education, and Balint groups. His current obsession is spending the winters trying to build the perfect backyard skating rink for his kids in spite of climate change. So on to you, Alan.
Great. I'm going to be chatting to you about a project that I was involved in. I am still involved in involving our humanities sort of program it's actually the undergraduate part of our humanities program here at U Ottawa Department of Family Medicine. And in particular, this morphed into although it didn't start out this way, it morphed into a project about addressing skepticism using humanities resources. There's the ice rink. So the cold weather is cold, but the great thing about that is it's great for outdoor rinks. Okay, just to disclose, I have received support from a PRIME grant from the Department of Family Medicine, and I'm working with DIME, the Department of Innovation and Medical Education, with our Corey LaDonna and Kate Scowcroft. Also want to just acknowledge and thank Doug for helping me with the PRIME grant, Huneda Abdi Hadar, who is another research assistant who's helping me with this project, And Mike Hirsch, actually, I'll just shout out to him because he helped to get the visual thinking strategies project going with the undergraduates. All right, so I'm going to briefly talk, just to introduce, set the stage, and then I'm going to talk about the study itself. I'm going to talk a bit about why we use humanities in family medicine education, the challenges, and how we can address skepticism in the use of humanities. So why do we do this? Partly, it's part of the CanMed's competencies. It's interesting when you look at this tree diagram. Family medicine expert is kind of seems to be the front and center. But all of the other roles involve competencies which utilize the humanities. And probably the best way to I guess, talk about why humanities is important is, I'm just going to quote what's known as the fish parable, which was part of a commencement address. The American author David Foster Wallace told this short story. He said, basically, there are two young fish swimming along, and they happen to meet an older fish swimming the other way, who nods at them and says, "Hello," or "Morning, boys, how's the water?" And then the two fish swim along for a bit. Oops, sorry. The two fish swim along for a bit, and then eventually one of them looks at the other and goes, "What the heck is water?" And really what humanities is, it's the water that surrounds our curriculum. So it is important, although we often do not actually notice it, even though we're swimming in it and totally immersed in it. I like to use this slide. I've used this slide before for other presentations, but when we talk about why it's important in family medicine is what I would deem a postmodern specialty. And for those who aren't sure what that exactly means, the values of postmodern theory are those of uncertainty, complexity, non-linear narratives, different voices and experiences of reality. The truth is perhaps multifaceted, and that is actually much closer to our experience as family physicians when we're sitting in our consultation rooms, talking to patients, trying to work out what's going on. And that theory usually makes more sense often than the modern values of a scientific rationalism. Remember that family medicine, and all this you know, because I'm speaking to a very well-informed group of family physicians. It's a generalist field, and it's defined by the person, not by bodily system, age, gender, or level of acuity. And our central role is the consultation and working out how to do that, working out why the patients come. We use the patient-centered clinical method. This is just one example of a model which we do teach both undergrads and our residents. So if family medicine is about the person, then it follows that we actually need the humanities, because it's in the center of patient-centered narrative-based medicine rather than in population-based medicine that the medical humanities play a significant role. And so that is basically what we need as family doctors, particularly at the coalface, but also in medical education. So we're going to talk a bit about a project in the undergraduate curriculum, because essentially this project leads to our competency in being able to conduct full consultations, and learning that should really start in clerkship. I'm going to just briefly talk about something called visual thinking strategies. So this is us basically at the National Gallery of Canada. This is one of the I guess components of our humanities program here at U Ottawa. And visual thinking strategies, essentially, it's an educational intervention that uses visual art to teach critical thinking, communication, and literacy. It was originally used for gallery teaching in museums, but is now used in a wide variety of environments, including medical education. And what we do basically is we take learners to a gallery, and then we ask, what is going on in this picture? There follows two other questions. What do you see that makes you say that? And what more can you find? So it sounds very simple, although it is a bit more complex than that. These are examples from the National Gallery of Canada of actual artwork that we have used to sort of go through this exercise. You can see some are probably maybe a bit what I would call easier than others. I want to talk a bit about some basic concepts in med-ed, because that's important as we sort of look at how and why humanities is useful, and why perhaps humanities sometimes can be a hard sell. Constructivism is the first principle. It presumes that knowledge is actually constructed from experience, and it doesn't exist solely independently outside of the viewer. It's a personal interpretation of the world, how we see the world, and learning is an active process in which we develop meaning based on our experience. So a teacher, such as all of us, are viewed not as just transmitters of pure knowledge, but as guides to facilitate learning. So that's the idea of constructivism. Kolb's learning cycle as a concept is also important to have an idea about, because when learners learn, particularly adult learners, it's again, they have to go through a cycle where they may have an experience, for example, go to the gallery or see a patient, and they can learn from that, but they need, for the learning to be deep and complete, they need to actually go through the cycle, reflect on it, conceptualize, and then experiment. Learners come into the cycle at any point, but in order to benefit the most from learning, you need to go through that cycle. So that's Kolb's learning cycle. I want to talk about briefly the concept of constructive alignment, which essentially just means any intervention, educational intervention you do should align with learning outcomes. So you need to make learning outcomes clear and explicit. Intended learning outcome defines what you expect a learner to do as a result of the learning experience, and it has to align with any assessment and the activity itself. And finally, there's this concept of social learning theory by Vygotsky. And this is important for an exercise like visual thinking strategies, because visual thinking strategies is a group activity. So you need other learners, and you learn through co-participation and interaction. Essentially, what we do is to stretch our learners beyond what they feel they can do on their own. And they sort of figure out what they can learn. This is known as the ZPD, the zone of proximal development. Now, I'll talk a bit about skepticism, particularly using humanities, because skeptics perceive that there's a gap between using humanities resources and applications to real-world clinical medicine. So we get this all the time for those of us who are enthusiasts on using humanities. Essentially, it comes down to a number. We did a lit review, and this is what skeptics kind of think. Firstly, is the content relevant? And skeptics will say, well, it is, but in an indirect way. The material is impractical. Concrete skills, such as starting an IV or taking blood pressure, are not learned when you use humanities. The question we always get, comment, how does visiting a museum help a student measurably improve patient care within a family medicine setting? There's the concept of intellectual bait and switch, as well, as that skeptics often will sort of come up with this. Medical students do enter medical school often having internalized the view that medicine is an objective scientific pursuit. Now that is changing, sorry. And, but I think that part of the reason of that is that we still have relatively narrow prerequisites for getting into medical school, very much sciencey based still. When you introduce humanities activities, you'll hear critics or skeptics saying, I didn't go to med school to be an art critic, for example. There's a preference for, if you are going to have humanities, they should be elective. There's a persistent resistance to the fact that this stuff is mandatory, I have to do this. There's no time, which is true. The curriculum is packed, and this should just be offered as electives to those who have an affinity and interest in the topic. And so if this continues, the presumption guarantees that there's always going to be a peripheral role for humanities in the curriculum. And then there's the teachers. So there's this idea of trustworthiness and socialization, because teaching medicine, obviously, it will require a lot of reliance on insiders, physicians, rather than outsiders. One of the criticisms is non-physicians don't comprehend clinical realities, and sometimes introducing this stuff can be challenging because students may resist sorry, there's a timer on this. I don't know what's, students resist personal engagement or reflection, discomfort with postmodern perspectives. I mean, there are many that are uncomfortable with that, that perception, that medicine, or particularly family medicine, is postmodern. And some may even feel threatened that they actually need character improvement or reformation, which is not the intention. And then there's the, where do you put this in the curriculum? Should it be in first year? It's too far removed from clinical setting. Second and third years are overwhelmed, basically trying to master basic clinical medicine. And fourth years are away on electives. So they're basically the best place to introduce medical humanities is nowhere, really. So that's often a challenge. So I'm going to talk about our study. At the University of Ottawa, we've had third-year medical students since 2011, and actually family medicine residents in our residency program since 2008 have done visual thinking strategies. We have been very fortunate to have in Ottawa the finest, the world-renowned Museum of Fine Art, which has an international reputation, and we use visual thinking strategies. So what we did with the study, there's a questionnaire that was collected, and we collected answers. And the idea of the questionnaire, actually, the original intention was really just QI, just for program evaluation. And this data was never really analyzed in detail. We read it, and we kind of just thought, okay, most people like the exercise, but we've never analyzed it. And so we decided to do a qualitative study using directed content analysis to explore the themes using all this data. The original study question we were thinking of was talking about the curriculum. How does visual thinking strategies help us to understand patient-centered care, essentially? But as we started to code the data, we changed this question. Often this happens in qualitative research, depending on what the data is showing, to what meaning does visual thinking strategies have for medical trainees within the context of learning? So this became more of a MedEd question. And the cohort that we were looking at were the third-year undergraduate med students who were beginning their 6-week clerkship in family medicine. And the VTS is actually part of a 1-week didactic sort of teaching session, which is sort of like the introduction to family medicine before they go in their clerkship. The other topics you can see are very traditional: diabetes, hypertension, dyspnea, fatigue, joint pain, dementia, etc. So these are all sort of fairly standard, classic topics. VTS, though, thanks to Mike Hirsch, was given its own half-day session, and it was one of 2 sessions that concentrated on process and contextual issues relating to family medicine. The other session was mindfulness, actually, which was also well received. Now, the attendance for VTS is mandatory for third years, and we actually collected data from 2011 to December 31st, 2019, because as we know, in March 2020, we couldn't go to the gallery anymore. And so that's why this is on pause. The VTS session took place, it consists of 3 such main phases, all at the National Gallery of Canada. First, we take the students to look at art. We take them through the gallery, and then immediately we do the VTS protocol, and then immediately following that, the group convenes for a facilitated discussion with family medicine preceptors to deconstruct the experience, and then they fill in a questionnaire on 145. And that questionnaire was mandatory so that students could claim credit for attending the course. So there we are again. And the questionnaire consisted of 2 open-ended questions, which were answered by prose. So no Likert scale. It was totally qualitative. What do you think of the teaching session itself? And what do you think of your personal experience with the teaching session? And this questionnaire came from a questionnaire that was found in this resource, the Arts in Medical Education. And then, so basically we had an archive of text consisting of verbatim written feedback with going from 2011 to 2019. We examined it by directed content analysis, which aims to validate or extend conceptually a theoretical framework or theory. We coded this data manually and also using NVivo coding software, and we subdivided and divided into themes. We got this through ethics to get an exemption to treat this as secondary data analysis. And essentially, the feedback data showed general satisfaction with the teaching sessions. However, there was critical feedback, and that was the interesting thing as we started to go through this. And that's actually fascinated us a lot more than the positive feedback was the negative feedback. we, generally speaking, just to try and quantify this, about 3/4 was positive of the comments, maybe about a quarter was not. That's based basically on word count and the number of pages and the number of comments we coded. So that's how we tried to sort of quantify it. This is just a classic example of a positive comment. There were lots of opportunities to participate, give input, communicate with peers. It gives family medicine a different angle than other specialties because it focuses on the narrative and art of communication as opposed to pure science and skill. It was very useful and unique. It stimulated new thoughts and insights on how we communicate with patients and how our impressions can inform our judgment. So that was fairly typical as we went through all of the positive comments. The negative comments we could divide into two main subgroups. One was just the practical points about content process and MedEd principles. So whether it was relevant to the curriculum, how clear the objectives were. Some of the artwork was deemed to be culturally insensitive, exclusionary, or Western centric, which I would agree with. And then, things like, I get what you're trying to do, but it doesn't fit my learning style. And then the other sort of group of comments generally were those problems that with values and expectations and sort of the philosophical implications of using humanities. So this is important, but I have better things to do, basically. I got no new insights. I was trying to always get the right answer. That was one of the things that was interesting when you take students through VTS. A lot of them are very focused on getting the right answer. So some examples, the relevance. So, and these are verbatim, just totally. So people would have had to think about this and then write it down and then send it through 145. So that's why we thought it was very interesting. This was a massive waste of time. Going to the art gallery was nice, but not relevant to clinical medicine. I wish this time should have been spent learning something. Generally a waste of time, inappropriate for an academic week. Artificial abstract does not directly relate to medical training. We had comments that it could have been more medical because we didn't show artwork that had an explicit medical theme. I thought the content could have been related more to healthcare. Using paintings with a more medical link may have improved the experience. We got comments about objectives. I'm not sure I can confidently say I found this to be a valuable teaching experience or valuable session for family medicine. The objectives were fairly unclear and I wasn't sure at times of the relevance. And then we had a lot of comments actually about competition with important parts of the curriculum. So this is a fun exercise for those of us who enjoy art. However, this is a little benefit to our medical education. I'm frustrated by the overemphasis on soft skills at this stage of my training. I do not disagree that active observation and listening are important clinical skills, but this teaching seems to come at the expense of hard knowledge. I fear I will complete this rotation having great communication skills without any actual medical knowledge to communicate. VTS sessions are best left for CME, not within the undergraduate curriculum. Again, this is just very verbatim. Competition with other important parts of the curriculum. I'm going to skip through these, but essentially, just for time. Other comments. This is not really a teaching session per se, but that's fine. I enjoyed the time out of the office. It was an enforced social activity masquerading somewhat as a teaching session. I'm annoyed that my academic week was wasted on a field trip to the art gallery. This is a great activity for 8th grade class, not a professional program. So these are medical students, third years, who will be practicing physicians in a year or two. The other comments that we went back to look at once we looked at the negative ones were what we called bridging comments. So these were initially coded as positive comments, but they did show some initial skepticism. And maybe about 6% of the positive comments were like this. So this is an example. Prior to attending the workshop, I felt that this was going to be a waste of time. We were consistently told in medical school there's an insufficient time to cover the material inadequately. I felt as though these 3 hours should be spent in a classroom rather than wasting time at an art gallery. But then the same person goes on to say, I could not have been more incorrect. The session was probably the most beneficial of the entire family medicine academic week. I really enjoyed the opportunity to explore new perspectives. It was really interesting to work as a group and appreciate the varying perspectives of my colleagues. So we did get some who were initially skeptics, not that many according to just what we saw, but we did get this. So what do we do? I guess what were some of the conclusions? We really need, if we are going to use humanities resources, I think it should be made clear to the learners, at least the concepts of constructivism and postmodern theory. They may not agree with it, but I think that it's important that they know that this learning is situated in that paradigm. We need to make sure there are clear learning objectives at the outset, and these are directly linked to learning outcomes and assessment, both formatively and summatively. Learners need to learn about learning, so they need to understand the Kolb cycle and how they actually learn, particularly experiential learning. Even though this activity does not necessarily suit everyone's learning style, there is still learning, there's always learning to be done. I often get comments from residents that aren't too keen to see a certain type of patient because they say the yield is low. I've done this, I know my heart failure. I usually say, well, there's always something you can learn from the patient. You may know a lot about heart failure, but maybe you might learn something about the patient. So I think that understanding how that experiential cycle works is important. It would be great if teaching sessions could be placed in higher priority, as in mandatory as opposed to elective sessions, to model their importance in the curriculum, and modeling behaviors among faculty and making faculty development sessions available to address the hidden curriculum barriers that exist can help to improve trustworthiness when using humanities resources. The strengths of this study are that we had a lot of data, like 10 years worth, which is a bit unusual. It covers the whole cohort of the third-year med students because they all had to complete the questionnaires in order to get credit. It was narrative prose, so there's no quantitative sort of aspect to this. And so we were able to use the qualitative methodologies to explore the potential themes more deeply. It is limited by the fact that content analysis itself as a methodology, as a method, is limited. This data was not originally created for research, it was created for QI. So it does limit what we can conclude as far as generalizability. Yes, and Corey, my co-researcher, did write a really excellent paper which highlights the limitations of using data extrapolated from analysis of open-ended questionnaires. So this really should be considered the first step towards further exploration about exposure to humanities, whether it produces an empirical outcome, and also to offer suggestions on how to improve engagement among skeptical learners. So the conclusions, it's important. Medical humanities should be playing a central role within our curriculum. We need to deal with skepticism, and we can do that to some extent by attention to basic educational principles, constructive alignment, experiential learning, understanding how learners learn, and embracing postmodern theory and constructivist approaches. So I'll take questions.
Alan, thank you very much. It's great to see and hear you present your findings from the studies. So thank you very much. We have time for maybe one question before moving to our next speaker. So first hand up is Can. So go ahead, Can.
For an excellent presentation. Having been part of the VTS facilitator group and also the teaching of the VTS program, I think it's excellent, and it provides the important capabilities and skills for our students. Now, my question is in regards to what we call quote unquote soft skills or people skills. What is your approach to the specialties who view this as only belonging in family medicine, when it should be something that we teach in all specialties?
Yeah, no, so that's an excellent question. For sure, family medicine, we should. To me, it's fairly clear that this is just a thing that we need to do. There are humanities programs popping up everywhere in medical schools. So I guess, depending on the specialty, and one could sort of, I'm making a big generalization, but surgery versus medicine, for example, I think that there are particular challenges. The more technical the specialty, I think the harder perhaps the sell. But everyone has to talk to patients. Essentially, if you have to talk to your patient, you need to do this. Not maybe like it's certainly a much deeper thing in family medicine, because that as I mentioned, our specialty is focused on the person. It's not focused on a disease or So I think that in undergrad, it's great that we have to expose everyone. So the 1/4, the 25% of the skeptics perhaps are not headed for family medicine anyway. That doesn't mean we shouldn't still be doing this, and doesn't mean that we shouldn't be addressing their skepticism, because really we want to bring this. We want to make this essentially just part of automatic. This is just part of a family medicine curriculum. So that's good. It's a good point you raised there, Kayan.
Ellen, thank you very much. Fabulous presentation. And please put your comments and questions in the chat. And I will now introduce our second speaker, Dr. Jolanda Turley, family physician at the Primrose Family Medicine Unit, graduated from McGill Medical School in 1997, completed family resident at St. Mike's Hospital in 1999, and then a fellowship in low-risk obstetrics, as well as a master's degree in family and community medicine from University of Toronto. She practiced full scope academic family medicine since graduation, including prenatal and obstetrical care. Delivering babies, even at 4 o'clock in the morning, is still one of her favorite parts of family medicine. Jolanda, over to you.
My talk this morning is actually about this sort of Meet the Doctor event that our call group has been doing. I have to say that I realize that these are research rounds, and this is not exactly, a rigorous research project, but I still thought it might be interesting to present some of these things and to have a discussion about this. There are no disclosures for this presentation. So by way of introduction, I'm part of a call group. We call ourselves the MAMA call group. We thought long and hard about our name and what that acronym stands for. But this is what we call ourselves. We're 7 family physicians and work at different sites in Ottawa. So Sarah Rice and Victoria Swan are at the Melrose Clinic. Chris Whitehead is at Riverside. Elena Sharapova and Flavia Sandy Mukasa are at the Somerset CHC. And actually, Sarah still goes there for a half day a week as well, because she used to work there. And then Rebecca Warmington, who is currently on maternity leave, and Rachel Lee is replacing her, is at the Centretown CHC, and I'm at the Primrose Clinic. So you can see that, we're at different sort of settings, different types of clinics, but we all have a very similar approach and a philosophy about sort of providing both prenatal and obstetrical care. But what's interesting is that the patient, patients that we care for are, I would say, sort of a fairly wide demographic group, and they have lots of different kinds of needs. So what's nice is that I think we all have the opportunity to kind of learn from seeing such a nice wide variety of patients, which is great. This is the group, actually, all of us, including Rebecca sitting at the end. And just to be clear, this was allowed in the summer of 2021. We were outside and we were allowed to be eating and drinking without masks on in that nice little pandemic reprieve we had last summer. So by way of background, I think it is now very commonplace for both obstetricians and family physicians to work in call groups. And of course, there's lots of advantages to it. It allows us to, juggle sort of multiple responsibilities that we all have. As everybody knows who does academic family medicine, we teach, we supervise, we obviously have our own practices. And most of us also have, kids and other responsibilities at home. In fact, a number of us in the group, not me, but a number of people in the group are actually also married to other physicians. So there's also the juggling of different call schedules. So you can imagine how tricky that all is. But the other thing is call groups, and I would say that this is definitely the case for us. We're also very supportive of each other in terms of, sometimes medical knowledge, sometimes sharing things like resources, sometimes debriefing kind of difficult experiences that we might have had, and even is supporting each other emotionally, because I think everybody knows that it can be somewhat stressful sometimes doing call and being at deliveries when things don't go well. I also believe that the call group does provide a model for our learners and our residents. But I think what people worry about or think about is, what about the patients? When I was a resident in the sort of late 90s, there were still quite a few family physicians, teachers of mine, who were those 24/7 type of, family doctors that did OB call all the time, every day, every night, and had perhaps some kind of, arrangement with colleagues for, like, occasionally if they were out of town, or, if they had a very important event to attend or something like that. But they were really doing call all the time. And I think a big motivator is also this idea that, well, you follow this patient all the way through their pregnancy. They may be your own patient, or, somebody you know really well, and you have to be there for that delivery. So again, when I was a resident, this paper was published actually in the Canadian Family Physician, and it was very, I think it was one that was considered to sort of be quite an important publication at that time, and certainly one that I remember very well. And in fact, I worked with one of the doctors who was part of this sort of research. And it was a large group of family physicians just north of Toronto in a place called Brampton. They all did OB, and they decided to form this call group. And there was a lot of reluctances first, again, like I said, because most people were worried about what their patients would think. And in fact, the results showed that 96% of patients had a different provider from their own doctor at the time of their delivery. And even with a group of 7 like ours, I will say that, most of the time my patients will be attended by one of my colleagues. And often when I'm on call and doing deliveries, it's one of my colleagues' patients. So this is very, very common. But in this particular study, almost 90% of the patients, though, were very satisfied with the care that they received. However, in the discussion of this paper, there was this sort of concern about having an unfamiliar provider at their labor and birth. So from this, this paper, and like I said, I worked with one of the physicians who was part of this group. When I first went into practice at St. Michael's Hospital doing prenatal care, I was also part of a call group. And we thought of this idea of having like a meet the doctor night to sort of mitigate this idea of having, somebody who at the delivery that you might never have met or seen or have no familiarity with. And so this idea kind of started for me in Toronto. We did this in the call group in Toronto, and then I brought it with me when I came to Ottawa in 2006. And I was trying to remember back, and I know some of the people on this presentation or attending the presentation this morning might have a better memory than I do, but I think we started these meetings around 2010 or so. And the call group has evolved a lot over the years because people have come and gone into the group. So at first these meetings were held at the Riverside boardroom, and then it was switched to the Civic campus. And these are the posters that we put out. We all have hard copies usually hanging in our offices, and now, of course, a lot of it is online. When we had in-person meetings, the attendance was fairly good. Usually between 10 and 15 patients and or couples would attend these meetings. For obvious reasons, we had to go to Zoom starting in April of 2020. But it was actually Dr. Viner, and I really want to credit him with this, Gary Viner, who said, we really need to be evaluating this. We need to be evaluating these meetings. And of course, he is absolutely correct. So starting in 2016, he created a survey, and we started handing this out after our meetings in 2016. And this is what the survey looks like. So there's just a couple of demographic type of questions at the beginning. And then a very, I would say, fairly simple, but meaningful sort of satisfaction, like of the different topics that we cover in our presentation, because we have a PowerPoint that we do during our presentation. Is it kind of too much, too little, or just right? And then we also have space here for people to make comments as well. And Gary put all of the data from these surveys into a Excel spreadsheet that we have access to. So we actually have data from almost 5 years, over 14 different meetings, so more than 200 responses. It's both from the pregnant patients themselves, but also their partners. And all of the different providers over the years, you know, at different meetings would have had patients attend. But unfortunately, you know, once we pivoted to the online Zoom meetings, we haven't had any surveys since that time. And that's something that I'll get back to at the end. Now, this is the part where I say that this is not exactly rigorous research. I use the eyeballing method of looking at the data and coming up with some, you know, things, which is that most responses, I would say, were in the kind of just right category. So Gary put them either in green if they were just right, or yellow or red if they were too little or too much. And if you look at, you know, the data, a lot of it is green. So most people felt that the information given out was just right. This is just to show that these are our meetings these days. They are Zoom meetings, and they also contain a whole section on COVID. And then there were, in the comments section, some, you know, suggestions for change. There were a lot of positive comments, people saying thank you, people saying how valuable it was. But I decided to sort of look at what was, you know, the most common suggestions for change. And a lot of it was just that people would like some more information about the different stages of labor, breastfeeding, things like that. Some people commented that maybe a handout with some key information would be helpful, which I thought was very interesting. Now, in the last few years, we have created a website actually for our group that has like pictures of all of us and information, and also a lot of links to resources and a copy of our presentation. So I feel that, you know, I feel like a lot of people now might be going to the website and getting some of that info. Some people wanted a bit more information about us, which is interesting. Some people actually wanted statistics on things like our group's rates of C-sections and other interventions. I think very often people are interested in things like epidural rates and, you know, episiotomy rates and stuff like that. It's very interesting. And then there was a few other things there. And one person said we should get valet service parking at the Civic, which there was actually the smiley face was verbatim. I would love valet parking at the Civic, but of course that's probably not going to happen. So again, this is, you know, sort of, again, a kind of like the gist of, you know, the responses of these surveys. And in terms of maybe bringing this forward, I actually do think it would be really interesting, and Maddie pointed this out, to look at this data a bit more formally and maybe actually do a little bit of a, like an analysis of it. But because I do think we have valuable data here to work with. I also think that actually tabulating statistics, as one respondent said, around rates of C-section and things like that would be very, very interesting. My understanding in the literature is that there is some data on this showing that, you know, generally speaking, groups of family doctors and low risk providers often have, you know, fewer interventions and things like that. So it will be interesting to look at our own group. Obviously, we actually spoke about this at our most recent meeting, which was just 2 weeks ago. Continuing the surveys electronically might be very useful. And some of the younger, much more tech savvy people in our group said that this would actually not be very hard at all. So that's an interesting idea. And we've often talked as well about, in some ways, trying to capture or survey those people who don't attend the meetings. Are there barriers there? Are there reasons why they're not coming? Maybe they're not interested, which is of course totally legitimate, but maybe we're actually maybe there are things we could do to make it more accessible for people. So that is one thing we've thought about as well. And we've also talked and thought about giving an opportunity for learners, some of our residents, maybe even medical students, to attend these meetings. Of course, now it being on Zoom, that would be so much easier, actually. So these are some of the ideas that I've had looking, in a kind of rough way at this data. And I am aware of the time as well. So I will leave it at that for now. I do want to give a huge thank you to my colleagues in my call group. Dr. Viner, of course, was sort of, really behind all of this, both Maddie and Doug, and also all of my colleagues at Primrose who often have my back when I'm on call and possibly getting called away in the middle of a clinic or some other thing. So I want to say thank you to all of those people. And on the right here is a picture of me and Julia Boutwina at the height of the pandemic, looking very medical as we go in to deliver a baby, actually. So I will leave it at that, and I'm open to comments and questions.
Jolanda, thank you very much. I open the floor to questions, everyone, or put things in the chat.
Hi, good morning. A really nice overview, Jolanda. And what I'll say right away is there's no need to apologize or sort of say this is, eyeballing or not really. I guess the value of what you presented is amazing. And I think it's about the reflective piece and, the usefulness of what you have found. And then there's definitely next steps that you could do, but it's not you who needs to do it personally. So suggestion to apply. And again, I would be very happy in the next day to help you put in an application for a summer medical student. The department will guarantee the salary if the person doesn't basically get the grant, and we have to pay, I think, part of it anyways, but hugely supportive. This would be an ideal project because they could start and finish in their 9 weeks. And then the other thing would be a resident research project, and also think about, I think the QI components in terms of the outcomes that you talked about are completely, that's a really nice project as well. And there are patient safety grants that are available through the Ottawa Hospital. Those are 20,000. And this one, if you thought about putting this together for the next round, again, is a very feasible and high value project. From the Department of Family Medicine side, obstetrics and the experience is something that we're really looking at and we want to support. And the more data and information that I have in terms of how the program is run and the experiences of how we do it, I think are highly valued. So please keep going. And thank you for presenting this at Grand Rounds, a very valuable presentation. And a great example, I think, of how things start, right? How do you take your idea or the things that you're working on that are your day-to-day and then start to, I think, look at it and understand, evaluate, and then also, there's huge potential, I think, to share. And that's what it's all about in terms of advancing the discipline of family medicine.
Thank you, Claire. I see another hand up. I will just say that, and Gary put this in the chat, and it's true. Over the years, we've all thought about kind of including, residents as far as like an FMRSP type of project, and medical students and stuff like that. And, with all of the people in the group, I think there's a lot of interest in that and a lot of motivation. So it's kind of nice to have kind of the ball rolling at this point. And I do agree that there's a big potential here.
What do you think about Zoom platform or some kind of platform such as we're using going forward, hopefully after the pandemic? Do you think that you'll go back to meeting in person physically, or do you think you're going to continue meeting virtually?
I think that's a great question. Thank you, Paul. And one of the things I didn't mention, but it is very interesting, we've noticed actually, a higher participation rate. And I don't have actual numbers, but it's clear that since we've had our Zoom meetings for the last 2 years, there's often 25, even up to 30 participants in those meetings. And, you know, I think all of us of the Mama group remember there was one dismal meeting sometime in January where there were literally like, we all made it to the Civic somehow through a snowstorm. And there were, I think, only 2 or 3 patients who showed up, which was obviously slightly awkward, but also felt like, you know, what are we doing here? So, you know, there are advantages to having it virtual. I spoke about, you know, the idea of some people maybe not having the opportunity to participate when it is in person, and then having it like on, you know, a virtual like Zoom and stuff like that actually might, you know, might be advantageous in a lot of ways. I'm not sure if we're going to go back to in person. It's a really good question, actually, because the truth of the matter is it has worked really nicely to be able to do it virtually. And yes, we've had great participation, definitely higher numbers than in person. So I think that's something we're going to have to think about, but I can see it maybe continuing virtually. It is very interesting because I have been at many, many deliveries where I, of course, go in and introduce myself, and then the patient or, you know, the partner will be like, oh, you know, we saw you at the meeting. So even just, you know, anecdotally, I can say that I think a lot of people appreciate, you know, like just having like heard you speak once or seeing you, you know, so it's definitely, I think it is appreciated by our patients. But yes, to think about, you know, other things like other kind of ways maybe of why it's working or what it's doing is a very interesting thought, Doug. I agree.
There again. Yes.
Yeah, just as an extension of that, I mean, to me, the applicability of what you're doing within obstetrics is the concept of team-based care at our clinics. And, you know, we don't do that. We don't, you know, what if we did do that? What if we did have, you know, even if it was just once a year, the it's like the meet the teacher, but it's meet the, you know, meet the clinic. So I think there it's you know, I think there's some really interesting concepts in there, and it's about, you know, so what do you need to have to actually start establishing a rapport, a relationship? So what you're reflecting is, you know, even on Zoom now, just with that session, just the face and voice, is it face and voice recognition? You know, what is it about your session? And I think, again, then there's, it's about introducing the team concept, and there's so much there. I'm not the expert on, you know, the theory behind some of that, those aspects, but you could really be exploring that amongst all the rest of the work that you're doing. So I would encourage you again to expand the team. Doug is available, I'm available. We've got, you know, writing support, and I'll mention that to Alan too. Alan, you and I have, and I've been dying for you to put this all together and, you know, publish and share the approaches on humanities. So what I can say is that Doug and his team have lots of support available, and I personally am fascinated in both of these areas and willing to read draft publications and also help review and get some grants going. So please, you know, please take us up on that, and very exciting work. So, and I will take the opportunity, since I see there's 1 minute left, also to personally, again, congratulate Sharon, and I'm extremely proud of all the work that Sharon, you've done, and extremely proud of the fact that you are the new scientific director at the Institut Savoie-Montfort. Alors, félicitations, et je pense que l'équipe and all of you, all of the faculty, tout le monde dans le département de médecine familiale, you're working so hard, and you know, the individual achievements basically, you know, folks get there because of the support of the whole collective. So thank you so much.
Well, on that note, I'd like to thank all of you for participating in today's rounds. Big congratulations to Sharon, and many thanks, Jolanda and Alan, for your presentations and discussion today. So I hope to see you next month in February. And as well, if you can fill in an evaluation for our sessions, would be great. So have a great day, everybody.